So thank you to all our speakers. We've really had an enjoyable session with all the topics so far. I'd like to now request all our speakers to perhaps get involved with the next session. This is I've had two cases that I've just organized for some discussion. Can you see my screen?
Yeah.
Yeah. So we'll go through some of the pertinent points that we've discussed so far. And the idea is just to try and apply some of the evidence that we've discussed so far. So the first case is a 64-year-old man who presented with painless visible hematuria. He's a smoker, smoking around 20 cigarettes a day for 40 odd years. It's a relatively fit man with a performance status of 0. He's had his routine bloods done, which includes a full blood count, Usenis or renal function test, and his liver function test, all of which were normal. If I can ask Nikita, this patient, how would you investigate this patient?
Thanks, Bhavan. So I'd see this patient in a one-stop hematuria clinic, and they usually have a urine analysis, microscopy sent off, and if this is negative for infection, we'd proceed to perform a flexible cystoscopy and ultrasound KUB in the unit where I work in. But considering this is a high-risk patient, male gender, older age group, and a heavy smoker, he would stratify as a high-risk candidate. So I would straight away organize a CT urogram proper tract imaging.
Excellent, Nikita. So based on whatever study we look at, we know that patients presenting with visible hematuria have a 20% cancer yield rate, and the majority of these cancers will be bladder cancer, a proportion will be renal and upper tract TCCs. We know that the incidence of upper tract TCCs are low. Gokul, I know you've done some work on diagnostic accuracy and screening. Do you think there's an argument in just doing an ultrasound scan in these group of patients, and only if an ultrasound scan shows an abnormality that we proceed with the CT urogram?
First of all, sorry, I can't start my video. There's some issue with it. I think they're looking into it. So you're only going to hear me, not see me.
That's okay.
So this, there are no guidelines regarding the upper tract screening, especially when you have done one form of initial investigation. So the second line upper tract imaging is something that we don't have proper guidelines about. And we did publish a couple of years ago highlighting all these changes, different sort of recommendations. Within our own data, we didn't find any advantage in doing an CT urogram when your ultrasound was normal. And invariably, all the upper tract tumors that we have picked up, they all showed some sort of abnormality in the ultrasound scan itself. That's what we found. But that's a single center data, of course. The only guideline which does recommend some sort of risk scoring and risk stratification, giving a score for each criteria, say like 2 points for smoking, 2 points for being a male, things like that, is the Dutch Association. They are the only one who give that sort of scoring system. And I think, if I'm not wrong, if your score is above 7, then you recommend a second line upper tract imaging. But the problem with that is that sort of guideline didn't withstand any validation studies. So again, that's a little bit of a debate. There are some medical legal issues in the mix that comes into picture when we discuss this. So what if you miss picking up an upper tract TCC by not doing an imaging, and the cost of that, the implications of that. So that comes into picture in some of the discussions as well.
Yeah, thank you. I think most of us would agree that patients with visible hematuria require being investigated. I agree, has a degree of debate and contention in it. Within our own, we do perform CT urograms in most older patients who present with visible hematuria, especially if they're above 45. So in this patient, we did do a flexible cystoscopy. and the flexible cystoscopy showed a solitary 3 centimeter left lateral wall tumor, and the upper tracts were normal. So the options in this patient, based on the discussions we have, is do the more traditional TURBT or en-bloc techniques, and the jury is out with that. We still don't quite know. But most units will continue to do a TURBT. Do you all agree that if this looks or endoscopically like a superficial tumor, that we must give them intravesical mitomycin C 40 milligrams pretty much as soon as we can? Any debate on that, or would all the panel members agree?
Yeah, that's beyond the debate.
Yeah. Okay. I'm just going to play a video just now, and this is just TURBT. This is the tumor here, and this patient underwent a TURBT. Based on the RESECT trial, what do you think, Nikita, are the quality indicators of good quality TURBT?
I'm not allowed to disclose that yet until we actually give you feedback. But in general, based on my presentation today, you need to try and do a bimanual palpation initially, examine the urethra and the bladder, resect the tumor and ensure you've got muscle in the specimen. Don't fulgurate the base if you haven't got muscle. Take biopsies of any red patches, examine the prosthetic urethra, and consider if you need to take a biopsy based on your findings. And then draw a bladder diagram and ensure that you've labeled the pathology specimen properly. And at the end, as we've already discussed, give intravesical treatment provided you haven't perforated the bladder.
Gokul, I think you developed the QPI indicators, or you had a big role to play in it in Wales. What would you add to that, or what do you think, Gokul?
I agree with all the points that Nikita just said. When you looking at a quality indicator, kind of looked at it from the evidence point of view, and then also from your local pathways and what factors in those pathways impact on the overall management of these patients, etc. Because one thing we know in bladder cancer is in certain patients where you need radical treatment, if you do not deliver the treatment within 3 months, that is a significant negative impact. So you really need to be on top of it. When you come into the specific factors, the muscle, the presence of muscle in the histology specimen is probably the single most important factor, and that's been proven beyond any doubt in so many studies, and that's a lot of good quality evidence for it. There are few, and the second one is the mitomycin, which we just discussed earlier. So those two are quality indicators that are settled beyond doubt. There are a few other things like completion of resection. Now, what if you don't actually complete a resection? Is it really going to impact on the long-term management? And what if you actually, bladder perforation is something that happens quite commonly, and does that actually really impact on the overall patient pathway and outcome? And then the time for TURBT, from the time you're done your cystoscopy to TURBT, and then your time for your second resection in those who need their second resection. And the indication is to do it within 6 weeks, and many a times that doesn't happen, and when that delay happens, and how much of impact that it carries. So all these things we don't have strong evidence on, but these are all built into in our quality indicators in Wales, so that we should be able to generate some data in the long run regarding this.
Thank you, Gokul. I think one of the earliest proponents of good quality white light TURBT was Bhavan Rai from Scotland, and some of the criteria that he used to define what was a good quality TURBT, as you said, was the presence of detrusor muscles, which was a surrogate marker of the quality of the TURBT, a complete resection, early intravesical therapy, and also a pictorial representation And it's interesting that with more paper-like technologies within hospitals, that the pictorial representation is becoming increasingly difficult to do. But in any case, these were the criteria that were put in. Do I have Zishan? Zishan, can you hear? Okay. If Zishan is not around, I'll proceed with the next slide. Now, this gentleman had TURBT. It's come back as a G3PT1 resection. Do I have a Vish as part of the team? Okay, so this patient's had a G3PT1. Gokul, what would you be your next approach in this patient?
I'm assuming there is muscle in the specimen, knowing that it's been done by Mr. Rai. So there should be a good quality TURBT with muscle in the specimen. But even if you have muscle in the specimen and it is still G3T1, I would still recommend to have another resection within that 6-week period, as mentioned earlier. It does carry a lot of relevance, and it does impact on the overall management. So I would send this gentleman for another resection.
So the reason why we do a resection is to ensure that there's no residual tumor or any upstaging, any residual tumor. Nick, can you hear me, Nick?
Can you hear me?
Yeah, Nick. So this is a young gentleman who's on re-resection, does not have any residual tumor. He's got a G3PT1 bladder cancer. What do you think the options here are, Nick, and what would you do in your practice?
So what I tend to do, Bhavan, in the re-resection is I do blue light re-resection, especially if someone's got initial T1, G3 disease, because having it done about 400, now this is slightly anecdotal evidence, but we do have the luxury of having blue light TURBTs up here. So we would do a blue light re-resection essentially to make sure that you do not have any additional concomitant risk factors, such as carcinoma in situ present, which can be present. But I think the case is discussed in the MDT as per usual. We look at the quality of the TURBT, etc. And then the options of discussion will be largely between intrarecycled BCG treatment, a clinical trial. We're just signing up for an interferon alpha 2B clinical trial, which has a similar cytokine release profile in the bladder, versus if the patient's really young, he's got a big T1, G3 tumor, then I may also discuss a primary upfront cystectomy with a neobladder or a conduit. But we tend to hold that as a backup option. You know, it's quite amazing that if you go to the US at their tumor boards, how different it is with T1, G3 disease. But I think in the UK and majority of places will go for BCG, and if they do develop disease, again, not so much in the context of an early superficial recurrence, but if they progress to muscle invasive disease, then the threshold is fairly low to proceed with the cystectomy. How old was this guy, Bhavan?
He was relatively young, Nick. But I think Nick has very nicely summarized what the options are. I'm not going to ask Nick what approach he's going to use. I think I know the answer to that. But we've had a lot of debate on robotic versus open. Is Arjun in the panel at the moment? Arjun, Arjun, in terms of your decision on the diversion as a functional urologist, what would your options be and why?
So, I mean, we've had some really nice presentations on, both robotic and open approaches to these. I think, the paradigm is slowly changing, but from a reconstructive point of view, as we've seen, we've got mainly the neobladder versus the ileal conduit. And, there are a number of factors which need to be taken into consideration. As we've seen, there are risk factors which we need to evaluate. And if there's any concomitant CIS, prostatic urethral involvement, that would preclude you from doing a neobladder. And we know that, disease recurrence in the urethra would be a disaster if you do a neobladder. So you want to make sure absolutely that there's very, very low risk of recurrence there. But also, I think patient factors also need to be carefully considered because dealing with a neobladder, although it might seem attractive to a lot of patients, especially the younger ones, it's not always as easy as it seems initially. So most of them obviously don't have normal bladder function, so they end up having to self-catheterize. Neobladders produce a lot of mucus, lots of recurrent risk of recurrent infections. So it's something that they need to be carefully counseled about by good surgeons, as well as good, I think, specialist nurses as well, who deal with a lot of these complications. And then obviously ideal conduits come with their own set of complications as well. So again, it's a counseling process, and it's not a one-stop shop. You just come and see these are the options and then say go away and think about it. It's something that I think needs repeated consultations with the patient and a lot of time, well, not a lot of time, but time to think about what the options are, what the risk factors are, and base the decision on those factors.
Thank you, Arjun. And clearly we can do this with extracorporeal and intracorporeal approaches. And I think what we can say is that it's important to follow the oncological principles, patient factors, and any decision that we eventually take will really depend on the surgeon expertise and what they're comfortable in. I'd like to go to the next case. This is slightly different. This is a 78-year-old man who presents with visible hematuria. He's a smoker, again, a risk factor. He's probably a lot not as fit as the previous gentleman. He's got hypertension, COPD, and he's got a performance status of 1. His bloods are otherwise normal. He has a tumor, which is small, not particularly big, in a large diverticulum in the left lateral wall, just above the left ureteric orifice. Nick, can I just ask you, what are your considerations in this patient who's got a tumor in a diverticulum?
So the patient 78, Bhavan, I think you got to evaluate his flow-urinary tract symptoms in detail. I routinely will get a 3 Tesla contrast-enhanced MRI done. And prior to embarking on the option of a possible robotic diverticulectomy with a reimplantation, also get a CT urogram done to look at the course of the ureter in the context if it sits proximal or close to the diverticulum. So I've just published on 10 of these, which is available online, again, in Current Opinions. But I think you have to be a little bit cautious not to over-treat a 78-year-old patient who has a tumor confined to a diverticulum with the anatomy of where it is. Considerations as a reimplantation, proper imaging have to be considered before. But I will do a cystoscopy and biopsy in and around the base of the diverticulum, not only before surgery, but intraoperatively too, with a frozen section backup in preparation for a robotic diverticulectomy with a plus-minus reimplantation, if it is oncologically safe to do so. I think an important consideration in these patients is that you have to counsel them that they will require adjuvant intravesical treatment depending on the pathology of what is being removed. So if they have high-grade disease in the diverticulum, which is superficial, they may require BCG or mitomycin C, but also a fairly interesting concept which has been floated in Belgium, and I've seen 2 of these being done, is essentially to do with bladder brachytherapy, in which you can remove that area and basically put some brachytherapy probes and irradiate it locally. But obviously your center must be in a position to offer brachytherapy too. So there are plenty of options, but bladder preservation is safe with regular follow-up in these patients, Bhavan. That's what I would say.
Thank you very much. I think what I've summarized is that in the early evaluation, endoscopically, the location of the diverticulum is quite important, particularly its relationship to the ureteric orifice. We must also be sure when we make our decisions that all the tumors confined within the diverticulum and what the status of the rest of the bladder is, if they've got disease elsewhere. And you may want to consider PDD-assisted cystoscopy, or in the absence of that technology, you could consider random biopsies as well. And as Nick has just suggested, an MRI may be helpful in local staging. Just 1 minute, let me get my screen tomorrow. So this was how the tumor looked like in the diverticulum. It was here, fairly large diverticulum and quite close to the left ureteric orifice. And we did some biopsies. This was a G3PT1 TCC. And as Nick has suggested, there are a few options. Radical cystectomy is an option, partial cystectomy is an option, intravesical BCG an option, and radiotherapy, maybe with evolving technologies where technology. As Nick has suggested, I think this really depends on patient factors. There's a lot to be taken into consideration before a final decision is made. And if a partial cystectomy is considered, particularly if the ureteric orifice is close to the diverticulum, there is a possibility of ureteric reimplantation, and that being the case, you do have concerns with reflux and as a consequence. But this is one of those cases which requires close and careful consultation with the patient. This is a shared care decision process, and I don't think there's any form of convincing evidence to suggest one is better than the other. Would the rest of the panel agree with that?
Bhavan, my only other tip, if you do want to start embarking on these tumors, you could see on your CT how close the ureter is on the back of the diverticulum. So you probably will need to reimplant the ureter on the left side. Is counseling these patients for the risk of strictures, etc., in the long term, medical legally, post reimplantation, which is something we need to consider, because the kidney may not function as well, especially if you do a reimplant lower down. So it was just something small which I wanted to reinforce.
Perfect. Gokul, did you want to comment on this as well?
I agree with what Nick is saying regarding role of partial cystectomy for a tumor within the diverticulum. Now, if it is PTA, I would probably be comfortable with it. When it is PT1 within a diverticulum, I would probably be more comfortable with offering cystectomy. Of course, there are all the other parameters, patient consideration, discussion with patient, everything comes into picture. But just purely from oncological perspective, I think a cystectomy would probably what most MDTs would be comfortable with as well, just because it's a T1 disease within a diverticulum. And in this particular one, if you look at the size of the tumor in the CT, it's fairly a large tumor. And you could probably use some nomograms here, and you probably will edge towards calling it as a highest risk bladder tumor, non-muscle invasive disease. That's another way of looking at it.
Yeah, excellent.